Hi there, welcome. My name is Sam Guild. I'm the president of AIM at Melanoma. So good evening or good afternoon, depending upon where you are joining us from today. I am really excited to be hosting what appears to be becoming a yearly tradition of ours, and that is to hold a webinar to help all of us better understand what the future of melanoma will be in the following year. So, there's been some exciting data that came out in 2022. And so I'm definitely looking forward to hearing, as I'm sure you are, how the data is going to be applied in the clinic in 2023 and beyond. I also hear that there are some exciting new developments that are anticipated in 2023. So I look forward to hearing about those as well. And to do that for us, I am honored to introduce two lovely ladies, Dr. Janice Mehnert she's a professor of medicine at NYU Grossman School of Medicine, and Dr. Erica Friedman, who specializes in melanoma surgery and surgical oncology at the Laura and Isaac Perlmutter Cancer Center at NYU. But before we get started, I just have one quick logistical note. We definitely encourage questions throughout the webinar. So if you are joining us via Zoom, please be sure to put those questions in the Q&A and not in the chat. We're concerned that the chat, they may get lost. So please use the chat to introduce yourself, say hello, let us know where you're joining us from. But it's really important to put those questions into the Q&A. And of course, if you're joining us via Facebook or YouTube, you can put those into the comments and those will be moved to the Q&A. So without further delay, ladies, I'm going to let you take it from here.
Thank you so much. And thank you for the invitation to speak. It's always an honor to do work for AIM at Melanoma. We so admire the important advocacy work you do for all of our patients. Dr. Friedman and I have sort of put together a few slides, but our vision for this talk is not necessarily to be an incredibly formal lecture style, but to sort of, run through some of the data that we have found most relevant to the management, some of the patients that we see together. We actually work side by side at NYU. We're on the same floor, clinic the same day, and we really believe in true multidisciplinary care for patients with melanoma. So I'm going to share my screen. And I direct melanoma and cutaneous medical oncology, and I'm the associate director for clinical research at NYU. And Erica is, again, part of the Department of Surgery. And I'm going to let Dr. Friedman begin the talk here with the new developments and new wrinkles in surgical management of melanoma.
Thank you so much, Dr. Mehnert, and thank you all for the invitation to be here. I'd love to share with you where surgery for melanoma is going, but before we do that, I have to explain where we've been and what we're currently doing. So fortunately, surgical excision is the mainstay of treatment for early stage melanoma with the goals of eradicating all of the tumor cells and decreasing the risk of local recurrence. I'm very fortunate that people like me, we get to cure most people. Next slide, please. So the current margin recommendations vary based on the thickness of the melanoma, which is the #1 driver of prognosis. So the thinner the melanoma, the smaller the margin. And you can see here, these are the current standards for the United States and largely the standards for around the world. Next slide, please. So one thing that we're looking at in the surgical management of melanoma currently is we're trying to investigate whether a wider margin truly is necessary. And this is being done in a multi-center, multinational randomized fashion by investigating 1 centimeter margin, which is a much narrower margin than we're currently doing, which is the current standard of care being 2 centimeters for the treatment of primary cutaneous melanoma. This is a trial originally run out of both Australia and the UK and is now expanded to multiple sites across the United States. Next slide. The hypothesis for this study is that there is no difference in disease-free survival for patients treated with either a 1 centimeter margin or a 2 centimeter margin, which is the current standard of care, for clinical stage 2 melanoma. And so these are patients with an ulcerated melanoma between 1 and 2 millimeters or any melanoma greater than 2 millimeters. The sub-hypothesis for this trial is that a 1 centimeter excision margin will reduce the risk of long-term pain and surgical complication rates. This was shown to be true in the feasibility trial for the MELMART study, which found significantly more patients in the 2 centimeter group requiring reconstruction, and those patients had a higher wound necrosis rate. The need for reconstruction, either a local flap or a skin graft, more than halved in the narrower excision group. Additionally, the study is looking at a 1 centimeter excision margin, hypothesizing that it will have an impact on improved quality of life for patients and change the use of local healthcare resources. While a very important endpoint, this particular endpoint is only being investigated overseas and not currently in the United States. Next slide. So as mentioned before, this is a randomized controlled multi-center non-inferiority international trial, phase 3. It's targeting accrual of almost 3,000 patients and randomizing them in a 1-to-1 fashion, accounting for stratification factors into one of 2 arms, either the 1 centimeter margin or the standard of care 2 centimeter radial margin. Again, patients are stratified based on their stage, age, sex, and country of accrual. Shown here is just a pictorial representation of the study design. So again, patients with either a 1 to 2 millimeter ulcerated melanoma or any melanoma greater than 2 millimeters are stratified to 2 centimeters, which would be the current standard of care for these folks, or a smaller 1 centimeter margin. Next slide. This is an illustration of how we go about actually measuring the margin, whether the patient comes to us with an excisional biopsy, a shave biopsy, or residual tumor in situ, as shown here. Next slide. The primary endpoint of the study is disease-free survival. And we're also looking at secondary endpoints of local recurrence, is defined to also include satellite and in-transit metastasis, distant disease-free survival, melanoma-specific survival, as well as overall survival, surgery-related adverse events, and adverse events within 1 year. Again, quality of life measures and health economic evaluations are only being pursued overseas. Next slide. So moving away from treatment of the primary melanoma, but investigating regional spread, part of the job of a surgeon is to not only perform the wide excision, but also to potentially pursue a sentinel lymph node biopsy to evaluate for microscopic spread into the lymph nodes. So a lymph node acts as our body's filter. It is typically the first place that melanoma would spread if it were to spread, and therefore is involved in the initial staging. The lymph nodes exist throughout the body, but are in the largest concentrations in the head and neck, the armpit, or the groin. Next slide, please. So when do we offer a sentinel lymph node biopsy? Again, the sentinel lymph node biopsy, the principle being that if the melanoma were to spread, it spreads to the lymph nodes, and not just any lymph node, but the first lymph node in a chain of lymph nodes. So we offer this procedure to anybody who has a risk of metastatic nodal involvement of roughly greater than 10%, being the cusp at which the risk of spread exceeds the risk of the procedure. So for example, a patient who comes to me with a 4 millimeter melanoma generally has a roughly 35% chance of having metastatic nodal involvement and would certainly be offered the procedure. When all comers with a 1 to 4 millimeter melanoma may have around a 20% risk. We do consider it in patients with primary melanomas greater than 0.8, with the range of 0.8 to 1 being this group of can consider, because again, we're looking at risk benefit, and the risk of spread in those patients is starting to exceed the risk of the procedure. We may consider it for thinner melanomas if they have negative prognostic features such as ulceration or a higher mitotic rate. Next slide, please. So what does this look like in practice? If somebody comes to us with palpable lymph nodes, they are not eligible for this procedure. They do have all of their lymph nodes removed. If a patient comes to me with no concerning lymph nodes and they have a melanoma greater than or equal to 0.8 millimeters thick, I usually offer them a sentinel lymph node biopsy. If the sentinel lymph node biopsy is negative, we observe them. If it is positive, we historically did a completion lymph node dissection. That means we went back and removed the remainder of the lymph nodes in that area. Next slide. However, in 2017, the standard of care largely changed, and that was as a result of a trial published in the New England Journal of Medicine fondly known as MSLT2, but formerly known as the completion dissection or observation for sentinel node metastasis in melanoma, whereas this trial looked at all patients with a positive sentinel node were randomly assigned to either completion lymph node dissection, which was standard of care at the time, or observation with nodal ultrasound. And the authors of the study found that there was no difference in melanoma-specific survival between the groups. Next slide. So shown here is the graph of those with who were observed in the red line and those who had a dissection. And the conclusion of this study found that while completion lymph node dissection did increase the rate of regional disease control, meaning fewer patients recurred in the nodal basin, and it did provide prognostic information, it did not increase melanoma-specific survival among patients with melanoma and sentinel lymph node metastasis. Next slide. This was a practice-changing trial, and while not what's going to happen in the future, it certainly has implications for how we surgically manage patients. So we went from a paradigm where all patients with a positive sentinel node had completion dissections, and now we've moved to practice pattern of active surveillance, which is defined as not only clinical exam, but ultrasound monitoring of the positive nodal basin. Next slide. So we're going to take a moment to look at how these surgical trials, both past and present, may impact the management of a hypothetical patient. And we'll move on to discuss adjuvant treatment as well. So we're talking about a case of a 70-year-old male patient who presents with an ulcerated melanoma 1.8 millimeters thick. He underwent wide excision and sentinel lymph node biopsy. He did have a positive sentinel lymph node, which made him a pathologic stage 3B. He did not have a completion lymph node dissection according to current standard of care. So what were his surgical treatment trial options? Well, he has an ulcerated melanoma between 1 to 2 millimeters thick, so he was technically eligible for MELMART, where he would have been randomized to either a 1 or 2 centimeter margin and potentially spared a more complex reconstruction by taking a smaller margin. Given the fact that he has a positive sentinel node and a stage at a 3B, it would certainly be, I would have sent this patient to a medical oncologist like Dr. Mehnert to discuss his adjuvant therapy options, which we'll discuss moving forward now.
Great, thanks, and I'll take it from here. So essentially, what do we have in the way of adjuvant therapy, especially for trials? Well, we are going to talk just a moment about data that have sort of led to one of our landmark studies, which is actually now closed, although a similar study will be opening up in the adjuvant setting. And that's a Relativity 47 study, which is a combination of nivolumab. Nivolumab is an anti-PD-1 inhibitor that many of you have likely heard of, that we use to energize the immune system to eradicate any residual melanoma in patients who have had surgery, or to treat melanoma that's spread in patients who are not amenable to surgery. Their disease is not amenable to surgery. So nivolumab, or anti-PD-1, is really, I like to think of it as the backbone of almost every medical oncology approach we employ. We use it, very, very routinely as an adjuvant therapy, meaning, again, medicine we're giving to patients to keep melanoma from coming back after surgery. We use it as a backbone of therapy for advanced disease. So it's a really important ingredient in our arsenal to fight melanoma. And many of you have heard about a drug called anti-CTLA-4 or ipilimumab. We use that in combination with nivolumab for stage 4 disease, especially disease that's in the liver, spleen, or brain. But then we also have these data, the relatlimab and nivolumab data, and this is also an option for patients with stage 4 disease. What you're looking at on this slide are data presented by my colleague, Dr. Evan Lipson, in ASCO 2021, demonstrating that if you give the relatlimab, which is the inhibitor of another checkpoint in your body called LAG3, combined with the nivolumab, you will have better progression-free survival versus the nivolumab alone. That's a very important piece of information. What does that really mean? Well, these are not overall survival data. The data are still maturing, and it may be some time before we know if giving the two drugs actually adds time onto a patient's life. But in the meantime, as we're gathering that data, many of us agree that progression-free survival is a meaningful surrogate endpoint. And what you're seeing here on this slide is that difference can be as much as 10 months versus 4 months in patients with stage 4 disease. So I think many of us have now accepted relatlimab and nivolumab as a standard in our practices. Where it actually fits, I think we're still figuring it out. But I do think most of us use this versus single agent nivolumab any day of the week. So when we have that in a stage 4 setting, the next logical thing we do is we go to a setting of patients who have had surgery and try to figure out, does this actually work better than single agent nivolumab in patients who've had surgery and they need to keep, we want to keep the disease from coming back. And that is the subject of the Relativity 47 trial. It randomized patients to single agent nivolumab versus the relatlimab and nivolumab. It was a blinded study. We did not know who was getting what drug. And that study is now fully accrued and closed, and hopefully this time next year, perhaps we'll have some data. In the meanwhile, there is another similar study coming down the pike from one of the companies that makes similar molecules. So have no fear. I think we'll have a study in this space as we're waiting for these data to mature. But this really was at NYU one of our state-of-the-art clinical trials that we had available to offer to our patients, and we did accrue robustly to this study. This trial, as I mentioned, is phase 3, double-blind and randomized. It was a 1-to-1 randomization. Sometimes when trials are designed, it might be a 2-to-1 randomization. So for every 2 patients that go on the combination arm, you have 1 patient that goes on the standard arm. And that's design is done for a number of reasons. Sometimes it enhances the statistical calculation of the endpoint. Sometimes we use that design because we have to study the therapy versus a placebo, and we want to minimize the number of patients getting a placebo. And so, but at least in this study, it was a 50-50 shot to either get the combination or the single agent therapy. And like I said, we did enroll several patients in the time it was open at NYU. But I think this has really been a very exciting year for understanding how to manage melanoma that presents before and after surgery. Because the trial that I just discussed is a therapy we offer patients after surgical resection. But what we've learned is that for patients who actually present with disease that is what we call bulky, meaning that it's palpable or advanced enough that the resection will be tricky, we now know that we can prime the tumor that's there with what we call antigen, meaning proteins that the tumor expresses for which we can develop immune response. So if you've got the antigen on board in the tumor, you can use medication to prime your immune system to respond in a superior fashion before surgery. What do I mean by that? I mean that what we've learned is if we're able to give a few doses of immunotherapy before a patient goes to the operating room, we can improve outcomes of event-free survival, and I'll get to those details in a second. But essentially, this is a schematic from a review published by my colleagues in Nature Medicine. And what you're seeing here, what's our rationale? Well, if you're giving adjuvant immunotherapy in that top panel, the surgeon removes the tumor and then we give immunotherapy and we have T cells activated. And we know, again, adjuvant therapy does prolong patients' time to relapse. So this is effective, but when we've got neoadjuvant therapy, as you see on that bottom slide, you've got that tumor ball in there and you give the medicine and you can activate the T cells while that foreign body is there and able to really incite a very strong immune response. So that way, when the surgeon removes the tumor, there's many more and more diverse T cells. And that is, I think, really exciting to all of us. So my colleague, Dr. Sapna Patel, was the lead author on a really important study done by the cooperative groups. And this is, again, to explain what the cooperative groups are. The cooperative groups are, federally funded clinical trials groups that often investigate questions that industry, for whatever reason, does not want to take on for themselves. And I think this particular study is evidence that sometimes that federally funded mechanism is really important because it allows us to design questions on our own that are going to be seminally important that for whatever reason, it just wasn't otherwise going to be executed. And this was a super simple trial design. Essentially, Both arms got 18 doses of anti-PD-1 therapy. The only difference between the two arms is that the neoadjuvant arm got 2 of those doses before surgery. And the other very unique thing about this trial is instead of measuring progression-free survival or overall survival, it actually calculated an important clinical endpoint called event-free survival. And that means that if a patient was waiting to go to the operating room on either arm and progressed, that patient was calculated in the analysis as an important event that we need to use to understand the clinical efficacy of what we're doing. And that's why it's called event-free versus just plain old progression-free survival. And what you can see on this diagram is that the blue arm, did much better than the bottom red arm. And that difference is not subtle. Those curves came apart very quickly. At 72% versus 50%, again, just by simply moving 2 doses of medicine before the planned surgery. So these are very interesting results that I think are going to change a lot of how we practice medicine and how we manage the care of melanoma patients. Before I move on, I think the last point I'll make about neoadjuvant therapy is, for the sake of time, I didn't go into every single neoadjuvant study that we have. This is just one drug that was given, but there are other regimens and studies percolating out there that use not just one drug, but 2 drugs. You may have heard of nivolumab and ipilimumab being offered before surgery, or nivolumab and relatlimab. So those data are, I think, out there. I think we also understand that they can really, induce meaningful responses in patients. I don't know that either of those are accepted as either one is accepted as a actual standard of care versus the other. And I think we'll see studies upcoming to help us understand the differences between all of these approaches. So I'm going to talk a little bit also about some other data that came out this year that was very important for patients who have metastatic disease, meaning disease that is unlike the cases we've discussed already, where it could be removed surgically, or whether the patient was given medicine before their surgery or after. And I'll start with a study called the DREAMseq trial. So essentially, when patients, come into our offices and they have stage 4 disease, meaning the disease has spread to the point that surgery is not useful, the first thing we usually do is look at their genomic profile, because that helps us understand whether or not they're even a candidate for targeted therapy. And for those of you who have been through being a melanoma patient, you've heard us toss around, BRAF mutation, NRAS mutation, c-KIT mutation. These are very common mutations that are oncogenic drivers of an individual melanoma. And if your tumor does have that BRAF mutation, you're a candidate for a class of drugs called targeted therapy. Dabrafenib, trametinib, encorafenib, binimetinib. There's a bunch of different agents out there. And again, this was a really important federally funded cooperative group trial to definitively establish whether we should give targeted therapy or immunotherapy first. Patients were randomized to either continuous targeted therapy, and if they progressed, they got ipi-nivo induction followed by nivo, or the flip, ipi-nivo first, followed by nivo, and then targeted therapy continuous. And the results were not, again, subtle. I think ultimately, while many of us had the gut instinct that in fact, immunotherapy would be the winner, we had to prove it. And this trial really did that. If you see that top diagram, again, you've got a 72% over 2-year overall survival rate versus a 52% over 2-year overall survival rate. So I think that we know now that there's better outcomes with immunotherapy first. That doesn't mean that we will always give immunotherapy first. There will, in fact, be times where, the beauty of targeted therapy is that you can really get a very quick response in a short period of time. And if a patient is suffering from an enormous disease burden, that may sometimes be employed first. I think that's probably the only place, though, where we're going to see targeted therapy given first to patients with stage 4 metastatic disease, now that we have these data. I think my last few slides are to sort of go over one of the more new, like what I like to consider a boutique-y approach to treating advanced disease. But I do think it's something we're going to be hearing a lot about in the next 6 months, because this may be something that actually achieves FDA approval. And that's something called tumor infiltrating lymphocyte or TIL therapy. So what is TIL cell therapy? Well, again, the immune system sort of identifies and destroys foreign and abnormal cells. And, we have, innate immunity and acquired immunity. Innate immunity is sort of something we, have as a non-specific first line of defense to eliminate, alien agents that are trying to make us sick. And acquired immunity is what we have hanging around once we actually get sick and have to clear those things. And our body's also in a constant state of immune surveillance, where both innate and adaptive immunity are working together to keep us healthy. So what TIL therapy is when, T cells, it exploits the T cells' potential to bind to foreign or abnormal cells through a process called antigen recognition. Meaning that when T cells bind to antigens on the surface of foreign receptor cells, they form a T cell and major MHC or major histocompatibility complex. And by doing that together, you're sort of really juicing up the immune system to fight cancer. And essentially you can have mutations in tumor DNA also cause changes in tumor protein sequences that can be recognized by the immune system as a tumor-associated antigen. So what TIL therapy does is it's exploiting this natural interaction that your body already undergoes. So because T cells can detect and eliminate tumor cells through neoantigen recognition, if you're able again to promote this interaction, it's something that you can hopefully galvanize to have the cancer controlled by inciting by using neoantigen recognition to incite this immune response. TIL therapy is complicated. This is not a simple process. First, you need to have tumor tissue that can actually be harvested from your body by a surgeon, and procured to actually, and then grown up and cultured to produce the tumor infiltrating lymphocytes you need to incite that immune interaction that I just described. So usually what happens is that tumor sample is taken, back in the day, academic centers did this themselves, and facilities called GMP facilities, the NCI has them. There's still a few places that have them, but now in today's day and age, a lot of times people are working with companies to actually grow up these TILs. So once the TILs are obtained from tumor tissue, sometimes it's done in-house at the academic center, but sometimes it's shipped out, and they're sort of co-cultured to try to expand the tumor infiltrating lymphocyte population that you're going to use to again, to give back to the patient to get their immune system juiced up. The difficult part of this is a lymphodepleting chemotherapy regimen, and that's to almost like a mini bone marrow transplant to sort of get rid of whatever active immune environment you may have while the TILs are being expanded in vitro. And then the TILs are, received from either the company or from the lab, and they're grown up and infused into the patient. At this point, they're expanded. They're polyclonal, meaning there's many clones of the original TILs, and they're really ready to start the fight against cancer that's remaining in a patient's body. And the final dose, and the trickiest, is when patients are infused with high dose IL-2. So IL-2 or interleukin-2 is a cytokine. And what that means is it can sort of induce in your body almost like a syndrome of septic shock, where your blood pressure can drop. Patients can bump their creatinine, honestly, as high as a level of 9 or 10, which, causes fear in the heart of many internists. But for those of us that have had to give this drug, a lot of times we can avoid dialysis in patients, even when their creatinine bumps that high. But what it is essentially a septic shock-like state in your body that we're again trying to do, because we're trying to really escalate the immune response, so that way the TILs can do their job. I think what is exciting about TIL therapy is that, we're probably going to start to see this become much more readily available, hopefully in the spring. And what we've seen, the results thus far have shown that, in patients that have disease for which other options have failed them, we can see response rates as high as 30%, which in a population that's, otherwise pretty sick is pretty exciting. The downsides of this approach are that, again, it's very intense. Patients need to be in the hospital for a large part of it. It doesn't work for everybody. And a lot of times also patients need to be able to wait for their tumor to be collected, the TILs to get grown up. And so this isn't a therapy that we're going to be able, to give, to every single patient. It's also important to remember that your body needs to be in a, pretty decent state of fitness to go through all this, to go through the lymphodepleting chemotherapy and the TIL infusion and the IL-2. So patients that have a lot of medical problems or who are elderly, this again may not be the right choice of therapy. But nonetheless, I think it's very interesting. I think it's something that will be a benefit to patients if we're able to expand its availability. And I think it's a space to really watch and pay attention to moving forward. So that's my last slide, and we're at 7:30. We did want to leave some time for questions. So I don't know if Sam, you'll come back on to help us moderate some of those. But I thought that that's how we would move forward with the last few minutes of this webinar.
Yes. So, hi. So, wow, that was pretty exciting. We actually already have some questions in the Q&A. So, Janice and Erica, if you want to just pop that open and then we can start answering some of them.
Sure. It looks like the first couple, I think, were directed towards me. Unfortunately, I do not think I wasn't going to talk about mucosal melanoma. It's not something I manage. I typically stick to cutaneous or skin-related melanomas, which I think Dr. Mehnert, I don't believe you were planning on speaking about mucosal melanoma, which was the first question in the chat. So our apologies. The location of the melanoma for the study for the MELMART-2 trial, largely we can randomize a patient with a melanoma in any location. There are a few select locations that would be an exclusionary criteria, such as if a 2-centimeter margin wasn't feasible, we can't randomize somebody. Tip of nose, ears, the tips of fingers and toes, but otherwise, unlike prior margin trials, which allowed us to kind of come to our current guidelines that largely excluded melanomas on the head and neck and did not include melanomas on the hands or feet, this trial does. So we're hoping to get really generalizable, robust results from this trial that will hopefully be practice changing and allow us to cut even less so that outcomes could be better for patients in terms of reconstruction related complications. A question from Facebook: can patients still opt for the old 2-centimeter margin if they choose? Unfortunately, if a patient is enrolled in a trial, they are randomized. So they're randomly assigned to either 1 centimeter or 2 centimeters. If a patient isn't interested in the trial, then we don't force them to be part of it. It is an option for some patients and something that is discussed, but by no means mandatory. And the current standard of care still is 2 centimeters. Really, the question remains is, do we need to do 2 centimeters? We've learned from prior trials that studied 2 versus 5 centimeters or 2 versus 4 centimeters that more is not better. It does not provide an advantage and does provide some negatives. So we're really excited to see kind of how this plays out. Then Dr. Mehnert, I think kind of there's a series of questions. Are LAG3 and PD-1 markers of response to IO in melanoma?
Yeah, and I think that's a really good question. So, the initial studies of the LAG3 inhibitor were that, it actually looks like LAG3 enriched for response. But, the problem with the immune system is it's a super dynamic state. And, it's been hard to pin down a single biomarker that helps us predict who's going to respond to immunotherapy. Excuse me. So essentially, PD-L1, we actually don't routinely test for it in our clinic. And, very rarely does it incorporate into decision making. So I would say that those are interesting things to watch, but they're not something we use, necessarily to help us make decisions. Is it still recommended to do immunotherapy for only 1 year? Well, essentially, it depends on the scenario. So for adjuvant therapy, yes, we usually do employ a year of therapy. But for metastatic disease, So we actually have a very interesting study going on called the PET stop study. I think it's pretty accepted that if patients have a complete response, a lot of people will stop after 1 year of therapy, even if patients, disease has spread widely. But we don't know that for sure. So what this trial is trying to do is really understand if we see that complete response and we get a PET scan and it's negative, can we safely stop? If it's positive, we get a biopsy. And if there's active tumor there, we're going to keep going with the therapy. And that's an ongoing study that we're running at NYU as well.
The question came up is, are there current margin recommendations for repeat in-transit recurrences? The goal of resecting a satellite or an in-transit that pops up after the treatment of the primary is really to achieve what we call negative histologic margins. We want to make sure it's gone when we look at it under the microscope. We generally take 1 centimeter margins out of convention, but there have not been trials that have specifically focused on the optimal margin. Again, we just want to make sure it's clear under the microscope. Is it possible to have 2 primary melanomas, 1 on each arm? It is certainly possible to be diagnosed with multiple primary melanomas. It is not the most common scenario, but it certainly is possible. And we see in people who have very, very thin melanomas and whom I can treat and be done with that melanoma, it's very low risk of recurrence. They certainly can get another melanoma sometime in the future.
Great. So we still have a few more questions coming through. So how long is the high dose IL-2 course in your TIL model? So I think the number of doses of IL-2 depends based on the TIL protocol. Some will give up to two or even, I've even seen 3 times a day for 4 days. Sometimes it's only 6 doses. I think what we're learning is it's, not essential to get every single dose in. Actually, this is something we've known about IL-2 for years. When I was a fellow at Yale back in 2007, my professor, Mario Snow, who's one of our, luminaries in the field, essentially, in order to be able to give the medicine on the floor, we had to actually negotiate with the hospital team. We didn't want to give it in the ICU. And the only way we could do that is to give only 2 doses instead of 3. And what we found when we did that is we got more of the planned doses in. So I think the conclusion is you really maybe don't need every single dose of IL-2. You sort of, again, it's like immunotherapy. You watch the patient, and if their body's reacting, you may need to skip a dose, and that's actually okay. So I think that will probably be, if TIL therapy takes off, something that we're continuing to look at. Do we really need that much chemotherapy to lymphodeplete? Can we get away with less? And can we get away with less IL-2? I think that's going to be very exciting to watch. So can T-cell for TIL therapy be harvested from brain tumors? That's a really good question. I think in general, the answer has usually been no. But to be honest, I don't know 100% for sure. I think if you were having a planned, intracranial resection and there was going to be fresh tissue available, it might be possible. But I think in general, it's easily accessible tissue, and the CNS is obviously not something you want to go tinkering around in unless there's a reason, like neurologic findings. If you've had nivolumab and a recurrence a few years later, would neoadjuvant therapy still be a possibility? Yes, I believe it would be. I think what we would do there, if you were to come into our clinic, we would look at your genomic profile and decide if targeted therapy was appropriate. But if you had just nivolumab and nothing else, you could have nivolumab with ipilimumab. You could have nivolumab with relatlimab. So we could do additional immunotherapy cocktails if you had just 1 site of disease or even 2 that we could surgically resect. We would absolutely consider giving you some medicine and working together. I think with the neoadjuvant approach, that's really where the power of having the multidisciplinary team comes in. If you're a patient who's going through neoadjuvant therapy, you want your surgeon and your medical oncologist to be in lockstep with each other. I think it's very important as you're giving the therapy to have the patient still checking in with the surgeon routinely, because there are, times where, something may be going on that may make that planned surgery tricky that I won't pick up because I'm not a surgeon. And so I'm very lucky. Again, when I have somebody doing that, I will have them routinely see, Dr. Friedman or one of our other surgeons to make sure that we're, all on the same page, working toward the same goal.
And I agree. If I'm sorry to interrupt,
No,
if
it's
that
good.
patient had come to me first with an isolated recurrence, let's say after treatment many years ago, that would be somebody that I would see and send to Dr. Mehnert as well, so that we can have a true multidisciplinary discussion, because there is probably not one best answer, but it becomes a little bit complicated, and we'd want to make sure to consider all the options.
And then the last question I'm looking at here is TIL therapy a consideration for a stage 4 patient who's already done Ipi-Nivo and all BRAF targeted therapies? Absolutely. Again, I think the beauty of TIL is that, we do see responses in patients where other therapies that we have available have failed them. And some of the more the more recent data that are coming out, there are patients who have, had 4 or 5, lines of therapy and it just haven't worked. And then, TIL does the job. Again, it's not everybody that gets that great response, but it's because of those responses that this, very intricate process that I described to you is worth pursuing, because, it certainly can be very useful in very tricky situations.
So Janice and Edgar, I hope you don't mind, but I'm going to ask you a question. So you have shared with us a lot of data, and it's pretty comprehensive, and there's a lot of information out there, and you can imagine how difficult it is for many patients to understand all of the options and then to determine what steps they should take next. Do you have any suggestions of the types of things that they should be asking their provider to help them make that decision about what they which direction they should be going in?
So do you mean like if somebody comes in and they have choices of like,
Well,
God.
Yeah, exactly. So for example, obviously some of these decisions will be based upon the stage of melanoma they have. Some of it will determine, for example, DREAMseq is applicable to those who have a BRAF mutation. But are there other things that patients, tools they could use to help them to decide what, which option or treatment they should be using, or sequencing, for example?
Yeah, no, I think it's a great question. I mean, I think the most important thing that you want to look for is someone who's really reviewing multiple paths of risk and reward, in terms of, treatment approaches, because none of our treatment approaches are completely benign and none of them are 100% effective. So I think that is really important. When I approach taking care of patients, I usually do go through every single avenue, but if I feel strongly, I will say, well, we could do X, Y, and Z. I really think you should do X. Because you're coming to me for my opinion, right? And I do, try to lay out all the data, but if there's something that's pushing me one way or the other, I will say that. There are times where I will say, you know what, this really is about what your gut is telling you, because the data are what they are. And there's not something in your case that's really driving me to say we should do X or Y. And those are much harder conversations. But I think it's really important to talk to patients about what their goals for their care are. Because, I think we don't do that enough in medicine.
Thanks. We have a couple of quick questions that came in. Do you mind answering them? And then
No,
we'll let you
not
guys
at all. So is there a protocol to rechallenge immunotherapy with fails, or would you try TIL first? That's a good question. And, we do immunotherapy rechallenge, even just plain old immunotherapy, that's not on protocol. We have a lot of trials actually for patients where the first line of immunotherapy has failed and it's immunotherapy plus new drug X. And those are all very reasonable options. To pursue that versus TIL, I think depends on a number of considerations. I think, sometimes, first of all, the most important consideration is whether the patient's fit to undergo TIL, and whether their disease can wait. In a situation like that, I might refer them to get the tumor start growing up kind of thing, and then put them on the trial in the meantime, because that can take a while to have the tumor grown and be ready. So I think that these are sometimes things that we have to navigate that can be tricky. Okay, I've had excision and then adjuvant Nevo and no period of recurrence. Would I ever do adjuvant again, even without new symptoms? So if you don't have another recurrence, you wouldn't necessarily need more therapy. There are situations where patients have a second recurrence and it's still surgically resectable, and then we do another cycle of adjuvant therapy. And the example of that is if a patient has a tumor with a mutation in BRAF and they had adjuvant immunotherapy first, and then it comes back and they can have a second surgery, then we'll try the BRAF therapy. And that is something that I think a lot of us are doing. We're actually trying to, develop a wide database internationally with outcomes here so we can, track what that looks like. But I think it's a very, very reasonable thing to do. And I'm concerned about permanent side effects with immunotherapy. Is targeting better options if they are BRAF positive? And did the trial separate BRAF versus non-BRAF? So yes, they did actually. And the benefits are BRAF or non-BRAF immunotherapy is very powerful. The good thing about BRAF directed therapy is, oftentimes when you stop it, the side effects go away. But you often also don't get those permanent gold star responses that immunotherapy is famous for. And certainly we hear you, right, that endocrinopathies can be, they're often permanent. They're not something that usually goes away when we stop the drug. I think if it's someone we're trying to cure, we do push through the development of those side effects. And, they are for the most part manageable, even if though they can, change your life. The hope is that they change your life, they don't change it. They might change your patterns of daily living and that you need to take medicines, but hopefully the quality of your life is not altered too much.
So thank you so much, Erica and Janice. I really appreciate, I think we all really appreciate you taking the time on a Wednesday evening to join us. I want to first, personally, again, say I really appreciate you all joining us, and I am incredibly hopeful that 2023 will even bring us even closer to a cure. I want to remind you that we, if you don't know already, we are recording this webinar and you'll have an opportunity to watch it again. Since there was a lot of information, you have the ability to do that as well as share with other people. If you do have questions that came up after the webinar, you're welcome to reach out to our Ask an Expert, Melissa Wilson, and we will be sure to share that with the email that goes out after the webinar, as well as with the Facebook and YouTube channels. Of course, we still have our Peer Connect program. I don't want to forget that you can reach out to Ann Garst-Taylor, our Director of Community Engagement. You need assistance with other information, or if you're looking to be connected with either a veteran or a newly diagnosed person. And although this is the last of our educational events for 2022, please remember that we are still here. We encourage you to reach out to us through the end of the year and into 2023, when we will be back again with more educational webinars, as well as our Beyond the Clinic Living Well with Melanoma, to help address your emotional needs with having a melanoma diagnosis. Again, thank you so much for joining us. Janice and Erica, again, really appreciate all of the wonderful and exciting information. I am really excited to see what we actually get to experience in the new year. So thank you.
Thanks for having us.
Thanks.
Thank you, Sam.